I think we'll make a start. So welcome everybody to the latest ECIST Webinar Series, which is part of the hospital-only discharge programme. Let me introduce myself. My name's Pete Gordon. I'm Head of Emergency Care Improvement with ECIST. Got a background in nursing, management and improvement. And today I'm joined by Dr. Gordon Caldwell, who I've known for 9 years. Gordon's a physician who I first met about 9 years ago when I joined ECIST, and I was overwhelmed with his brilliant work around inpatient wards, ward round checklists, earlier discharge, which is the topic we're going to talk about today. Gordon, would you like to introduce yourself?
Yeah, I'm Gordon Caldwell. I'm a consultant physician. I worked from 1993 to 2017 as a consultant in Worthing Hospital in West Sussex, and that's where I started work on ward rounds, particularly training on ward rounds and quality and safety on ward rounds, and did some work towards the end of that on earlier in the day discharges. And 2018 I moved up to the west coast of Scotland, where I work in a small hospital in Oban now, where discharges are coordinated to meet, for example, ferry timetables. Thank you.
Brilliant. Thank you, Gordon, and it's an absolute pleasure to have you with us. So the way we're going to structure today, the session is going to be recorded and it will be on YouTube a little bit later on. I'm going to start off with a few slides just to set the scene, but the majority of the session will be a conversation with Gordon and an open conversation with everybody on the call. So I'm just going to start off by sharing my screen. So hopefully you can see that.
Yes.
So the area we're going to talk about today is earlier daily discharge time. So that's really the focus. And some of you may have heard of something called the patient flow bundle. And this is something I created, which was really designed around inpatient flow. And one of the key elements of it is earlier discharges. And we're also going to talk about, if you get earlier discharges, that earlier movement in the day of patients. But I'm not really going to talk about SAFE today, just saying it's a key part of it. So what's the problem we're trying to solve? Well, this slide here is typically what emergency admissions look like in an acute trust. So they sort of peak around lunchtime and also peak around tea time. But when we look at admissions and discharges, this is typically the pattern. So the discharges and the admissions don't match. So we have this period of time in the day, which you all recognise, where we don't have beds available. So that's the sort of problem that we're trying to solve. But if we could match, or at least bring the discharge time earlier, it would make things much better, not just in terms of patient flow, but also for patients as well, which we're going to talk to Gordon about, the impact on patients. Are the papers around, does earlier discharge make a difference? There are. This one is an Australian paper, which basically says that if you can create earlier discharges in a day, it improves patient flow. One of the things we will send out after the webinar is our rapid improvement guide. It's a 2-page guide which just contains top tips for earlier discharge, including, and these are some of the things we're going to cover off in the conversation with Gordon, is for patients, when can they expect to go home, the importance of having a clear plan, practical aspects such as transport, that age-old problem of medication to take home, TTAs or TTOs, and discharge letters. And I've just put in a box there from a study by HealthWatch when they asked patients, so people who've been in hospital, 61 of the respondents reported that their discharge was delayed. The most common reason given for delayed discharge from a patient's perspective was waiting for medication. Thinking about those slightly more complex patients who need support upon discharge, we could probably cover off a little bit around criteria-led discharge, but we've got a webinar on that next week. And then probably talk to Gordon around how we use, simple information to understand how we're doing and reduce constraints. And I'm going to embarrass Gordon now by, this is a graph that he shared with me when he wrote a brief piece on, and he called it scheduled on-time departure from hospital. And so on his board, you can see he managed to get well over 30% of discharges before midday. And one of the things he did was he slowed down to sort of speed up, and it didn't have a negative effect on length of stay. So that's just me setting the scene. I'm going to stop sharing my screen now. And Gordon, first question I'm going to ask you and get your thoughts on is, thinking about patients, from a patient's perspective, why is earlier discharge in the day important?
When we're talking about earlier in the day discharge, I'm talking mainly about what I'd call a patient with complex needs. And it seemed to me, from my experience over the years as a consultant, that patients really fell into two groups. One where it was an unsupported discharge and the patient could walk out to the ward and look after themselves, which is relatively straightforward to manage. And everything else seems to be complex, whether it's just that they need a little bit of help at home with their medications, or whether they're being discharged to a nursing home. Or supported at home 4 times a day visits in what they call in Scotland a tuck visit at night, something like that. And with those patients, it seemed to me that if we might have been aiming to discharge them during the morning, but almost inevitably they ended up being picked up by the ambulance at 3 o'clock or 4 o'clock or 6 o'clock even, getting back to their house or to the nursing home and things not being ready and frequently falling apart then. So it struck me that for those patients with the complex needs, we weren't serving them very well by discharging them in the afternoon or the evening. And it'd be much better if we could schedule a discharge early in the day and complete the discharge early in the day. So I was thinking the benefits for the patients would be they knew when they were going home, it was a scheduled time, it happened, they got settled in properly at home or in the nursing home or care home early in the day. So the driver for it came, what can we do to make this easier for our patients with complex discharge needs? Thank you.
Gordon, and in terms of communicating with patients, what's your approach to communicating when patients can expect to go home? How do you go about doing that?
Well, I think firstly, it's the one question that I think every patient asks. If you give a patient an opportunity to ask anything at the end of a consultation on a ward round, the one thing that everybody wants to know is when can they go home. So again, this is focusing on the patient's needs, perhaps rather than the flow of the hospital, is that as soon as somebody's in hospital, they want to know when they're going to go home. And again, as a consultant, maybe after 5 or 10 years of experience as a consultant, I think it was fairly straightforward to identify patients who are likely to go home within 24 hours, where it might be 3 to 5 days, or 5 to 10 days, or a very long time. So I think as soon as I was had met the patient on what we'd call a post-take ward round or an admitting ward round, or even sometimes when I see patients in accident and emergency, I will discuss with them, I anticipate that you will be in hospital for 3 to 5 days or 7 days to 10 days, and we'll keep that under review and update you. So just broad categories like that, and talking about it on every consultation, which picks up on something I'm sure we'll deal with later on, that if the nurse is present and participating during that consultation, then the nurse hears that as well and communicates that to the therapist. The doctor, the consultant, thinks this patient will be home in 5 days' time. So it gives a focus. So I'm always talking about when I think the patient will be ready to go home, no longer need the care of a doctor, because it's very important to the patient and it helps the whole planning right from the first contact. Thank you.
And Gordon, we were talking yesterday about this. I mean, nursing's my profession, so I'm a big, huge advocate of nursing. Can we just talk through the importance of, the nurse's input in terms of when we're thinking about ward rounds and the expectation of earlier discharge?
Well, to me, I qualified in 1980, long time ago now, and in those days, it was the tradition that the ward sister or the charge nurse was always on the consultant ward round. So the communication about the status of the patient's functional ability, was always part of the discussion, and the nurse was an active participant in those discussions. So it's caused me distress over my career to see that the participation and involvement of the nursing staff has decreased. And it's very easy as the doctors to make fairly major errors in discharge planning, because we'll say to the patient, oh, can you manage your own meds? And they say yes. And can you get yourself to the toilet? And they say yes. And did you dress yourself? Yes. And what did you have for breakfast? And they tell you. And we believe all that. Whereas if the nurse is there and the consultant leads the team and shows, values and respects the nurse's input and requests the nurse's input, the nurse is free to say, no, patient didn't get out of bed, needed 2 people to help and nearly fell on the way to the toilet, has no help at home, and this is going to require another 3 to 5 days of planning. So to me, the cooperative working of the doctors and the nurses at the patient side, not just at the handover meetings, but actually at the patient side, is crucial to the swift flow of the patients through their admission. Thank you.
Yeah, thanks, Gordon. And there's plenty of senior nurses on this call who I know, so we could maybe pull a few of them into a discussion around that a bit later on, because there's lots of constraints. So let's move on. So when you were doing the work in Worthing and you delivered these impressive results, so can you talk about sort of some of the top 3 things that sort of made the difference?
Well, I suppose I should say where the idea came from. And I think I was thinking, people are always comparing hospitals and air traffic safety, and I was thinking about the similarity between discharging a frail patient with care needs to the similarity of maybe taking a similar person on a transatlantic flight. You wouldn't get your frail grandmother with early dementia ready for a transatlantic flight at 7 in the morning for a flight at 11. You prepare everything the day before, get everything in order, make sure everything's in place, double check it. And then on the morning, all you need to do, get up, get dressed, get the suitcase, the passport and the credit cards, and drive to the airport and get away. So I was thinking that doctors often talk about the estimated date of discharge is Thursday, whereas I was talking about Thursday at 9 o'clock. And could we get the person out of the ward at Thursday at 9 o'clock on time, in the same way that we expect our EasyJet flights to be on time? So that was the background to it. And with what I'd said earlier on about our failures once the discharges are in the afternoon, it seemed to me that it might be better to, as you say, slow down, keep the person until the next day and discharge them at 9 o'clock in the morning. So maybe on a Monday, I'd be saying, you will be going home at, all things being equal, Thursday at 9 o'clock in the morning. And if that's inconvenient for your relatives or it proves it's difficult for the transport, in Worthing Hospital, we had a discharge lounge, and I think this was crucial to the success of this scheme, would say you will be leaving the ward at 9 o'clock to the discharge lounge if you're not going directly home. So again, the expectation was there. It wasn't just suddenly landed on them at 10 to 9 on Thursday morning. Oh, you're going to the discharge lounge and you're going to have lunch and home at 2 o'clock. So again, it's this concept of always talking about this with the patients when they're going to be going home, always reviewing it with the patient, with the nursing staff and the other allied healthcare professionals. And then probably say it's Thursday morning discharge on Wednesday afternoon, just reiterating that, being able to say to the nursing staff, tomorrow morning this patient can leave the ward without the need for a doctor's review, provided there's no deterioration or unexpected events. And you don't need to wait for us to come on the ward round. That would allow the patient to either to be discharged at 9 or transferred to the discharge lounge at 9. That would mean in turn that the bed was ready for 9:30 or 10. A nurse could go down to the acute medical unit and say, I'm from Castle Ward. Have you got any suitable patients for Castle Ward this morning, please, on the acute medical unit? Patients would then be up on the ward by 11 o'clock, 11:30, and we could review them that same morning, the next patient. And this was crucial to how the slowing down speeded things up, because you all know that doctors find it difficult to decide whether to discharge somebody unless they know they are improving and getting better. And you have to see a patient twice to know they're improving and getting better. So the patient who used to arrive at 5 o'clock once our ward team had gone away was arriving at 11:30. We could see them before lunch, and the next day in the morning we could say, oh yeah, you're obviously better. You're a simple discharge, you can get away now. So the fact that the flow through the wards actually improved by slowing down was due to the fact that we had the patients early into the bed the next day, could get an early review so that on day 2 on our ward, we knew they're improving and could get out of hospital. I think those were the main things, Pete.
Yeah, brilliant. So there's a number of benefits there. One of the benefits that we'll probably bring in one of the ED consultants on the call a little bit later on when we open up to questions, is the early pulling of patients. So by getting those patients scheduled out at 9 a.m, the nursing teams can communicate with AMU and pull that other patient up. And I guess the other thing is, we were talking about this yesterday, is your ward was typically full at 6 o'clock. So for the nursing team overnight, they knew their workload, and you reduced the transfers, particularly of frail older people, after 6 p.m.
Yes, with this approach, we tended to have the ward full by mid-afternoon, whereas with the old approach, sometimes people would be discharged at 6 o'clock, the bed would become available at 9, there'd be bed pressures at 10 p.m, the patient come up at 11. As the nursing staff, you're usually understaffed at night, you've got a new complex patient to deal with, there's a lot of noise and interruption for the other patients. So I think one of the reasons this was successful, because obviously we were working on a very functional unit, Castle Ward, where all the patients on that ward were under our care. The other consultant and I negotiated to take on a larger ward, provided we could have all the patients on the ward. The charge nurse and sister were very keen on this, and the night staff found that the night work was much more acceptable because they weren't constantly interrupted with new admissions and noise. So those night staff, when they moved on to the day shift, knew that it was important to get down to the acute medical unit once the bed was available and try and find the next patient to come up, because then they knew they're helping the other members of the team to have a more acceptable night, and for the patients to have a more acceptable night as well.
Yeah, brilliant. Keep the comments coming in the chat. I can see those. So we're going to talk about sustainability, and one question I think that will be on everyone's mind, and it's the age-old problem of TTOs. So in terms of that, I always say when I'm out and about, especially if there's a group of nurses there, I sort of say, do you have to chase TTOs? And they typically all laugh at me, you know, ward teams. My wife's a ward manager, so I hear about these type of things every day. So in terms of the TTOs and the letter, which is typically a constraint and takes lots of chasing and stuff. Well, how did you deal with that? Did you do any the day before? How did you approach it?
Yes, well, these patients, I'm sure you'd recognise, are generally patients who have a longer admission. They're not patients who are going home in 24 hours. It would be 5 to 7 days or longer. And we'd maybe on Monday be anticipating discharge on Thursday, which would mean that on Wednesday afternoon, the doctors doing the discharge note and the nurses doing the discharge note would do that on Wednesday afternoon. Often in the afternoon, the doctors found it was slightly quieter, and that the ward pharmacist would then go through those complex discharge patients with the ward doctors and resolve the problems that perhaps usually were done over the phone and took forever. They could sit down and maybe in 10 minutes, just quickly, 10 minutes, check through the TTO list properly. And of course, we're anticipating the patients are stable and there's no last minute changes, intravenous to oral switches and things like that cause all the usual problems with TTOs, that it should be a fairly stable prescription. So that was all, again, prepared on the Wednesday afternoon. So on Thursday morning, it really was a matter of collecting the medications, moving the patient to the discharge lounge or discharge usual route through the nurses, through the ambulance, or relatives picking them up. Yeah. So okay. It was doing the work the day before and making sure it's all ready. Yeah. Occasionally we had patients where something unexpected happened overnight. I think we had a lady who had come in with a small stroke, who developed sepsis at 8 o'clock on the morning of discharge. Well, of course, again, that's team working with the nurses. The handover, they're saying, Mrs. Smith, unfortunately can't go to the discharge lounge. She's developed sepsis and a fever. Right, fine, change the plan.
Brilliant. Thanks, Gordon. And one of the things that's coming through there is the trust between yourself and your consultant and doctor colleagues and the nurses and AHP. So if I was the nurse in charge of the ward for the patient in question and everything had been prepared, you'd be happy for me to discharge that patient as the nurse in charge?
Yes, I think that took quite a bit of work the first few weeks we were doing this, because our nurses weren't really used to that, or perhaps they were used to it at weekends, but at weekends we all had to fill in an A4 document with everything reiterated and exactly what the criteria were for discharge. Whereas with this, again, we're in a functional team, we could say, late afternoon handover, yes, Mrs. Jones is set for discharge at 9 o'clock tomorrow morning, definitely doesn't need to wait and see a doctor. You can just take her off to the discharge lounge or hand her over to the transport paramedics for her to be discharged. So that took a little bit of time for that to sink in. Yes, we really meant it, and we'd back them up.
Yeah, which is, I think it's a powerful message. Another constraint that comes up a lot around early daily discharge is the issue of transport. So have you got any sort of thoughts or tips around that?
Well, again, the earlier it's anticipated, the better the chance of the transport being put in place. So if I'm saying on Monday it's very likely they're going to be going home on Thursday and I want it to be 9 o'clock, then it's much more chance of getting the transport if I've said that on Monday than if I say it at 6:30 on Wednesday evening. And I mean, it's not just the transport, as you know, it's working with the occupational therapist to make sure the commode's been put in or whatever. So there's all those aspects. The earlier we're planning, the more we're discussing it, the more chances is it's going to happen, I think. I haven't been involved, obviously, in NHS England since the pandemic and the huge pressures you're under there with transport, which must just make things much more difficult.
Okay, thanks, Gordon. And before we bring a few other people in, just a couple of other areas to cover. So in terms of having a good plan for every patient, so it's really clear, you know, for example, it has physiological and functional criteria for discharge. Is that something that you were, you know, did and how did you include that in your ward round checklists and things like that? So,
you know, well, you mentioned the checklist there. I think, I mean, what I recognized around about 2007, something like that, is that there should be a structure and a process for the review of patients, and it shouldn't just be left to us turning up and wondering what comes first into our mind when we see the patient and hope that we've done everything by the time we leave. So I was interested in what the whole team, nursing and doctors and the other allied health professionals, thought constituted the regular review of every patient that we should go through every time, every patient. So that fairly soon evolved into a checklist, which in the early days we used to give to the medical students and say, you've got the most important job today, which is to make sure we don't forget anything for our patients. And one section of the checklist, daily checklist, was always about the discharge. Was the discharge simple or complex? When did we think the discharge was going to happen? The latter sort of checklist I've been running in Oban ask questions like, does the patient usually manage their own medications or do they need support? Sort of crucial questions around that. In Worthing, yeah, just before I left there, we managed to incorporate that into a standard format ward round document, 2 sides of A4, which also I've done in Oban now. So on 2 sides of A4, you can see all the information that I think is usually held in about 50 sheets of doctor's notes and nursing notes, and you can actually see what's going on as well. And you can see when the patient deteriorated, we changed the estimated date of discharge from Monday to the following Wednesday. So having a structure and a process, also that structure and process enables the nurse to be much more of an active participant because they know the information I'm going to ask. You know, another bit, Pete, was about, I'm not sure what you call them now, the stranded patients who so rapidly decondition. So we always ask, you know, what's the best activity the patient's done today? Have they been out of bed and walking and things like that? And if they're walking, what support do they need? So a lot of emphasis in my checklist on whole person approach to their care. So as a consultant, I'm showing an interest in whether they're continent and whether it's, if they're incontinent, it's just urinary or fecal, how are they doing with eating and drinking, all these different aspects that are so crucial to a timely discharge of a frail elderly patient.
Brilliant, thanks, Gordon. Before we, I'm just going to bring a couple of other people in on the call. I'm going to bring in Andrew Rochford just to briefly talk about modern ward rounds, just very briefly, and then we're just going to ask Ben Owens a question, who's a consultant from ED, who are both ECIST doctors, and then I'm going to open this sort of open it up to general questions. But the last one for you, Gordon, so you can take a breather for a second before we go into the questions, is there was a question around sustainability, sort of sustainability and measurement. So, you know, sometimes we do these improvement efforts and we get an improvement, but we struggle to sustain it. Any tips around, you know, for the people on the call today, if they make the effort, how do they sustain it?
Well, I can't overemphasize the need for perseverance and commitment. Crucial, I think, to this question of the early in the day discharge was getting our patients geographically into one ward, which was where the team functioned, and the sisters and the nurses weren't having to deal with 6 different ward rounds simultaneously. Now that took me, I think, between 10 and 15 years to achieve in Worthing Hospital. So once we'd achieved that and we'd got to this level where it was our ward with our ward rounds and our staff, and we were all working together on behalf of patients, then we could take this work on, and I think and keep it on a sustained basis. The measurement side, I think measurement, you're all, I'm sure, extremely busy, and you're not offered any nice support like Pete coming to work with you every day for 8 weeks. So anything you measure has to be really, really simple, and it has to be meaningful. So on my ward rounds, pretty much all we measured was how many patients are there, how many are new, how many are review, how many are critically ill or deteriorated, how many might be anticipated to die in the next 24 hours, how many staff there were on the ward, what grades they were, what professions they represented, how long the ward round took. And I documented, was there an active nurse participating in the patient review at the bedside? I should have asked, was there an active pharmacist involved at the bedside? But in Worthing, that almost never happened. And those very simple statistics, I think, brought home to me the importance of proper open communication at the patient side between the doctors and the nurses, because the nurse is crucial, is the hub of the patient's care, has to know everything that's going on, and has to know the detail and the subtlety that comes through from participating in the bedside review. However good the handover is, it's very functional, very brief, and not really full of the subtleties and the ease of communication. So when I left Worthing, I think my statistic was under 20% for nurse present at the bedside, and I counted any nurse who said good morning at the bedside as present. When I moved up to Oban, the tradition was vastly different, and it's close to 99% of the occasions that we do a review, the nurse is there, and we get told off if we go and review a patient without a nurse. And the richness of communication that happens at the bedside when the nurse is present and encouraged to participate freely, I think helps the whole flow of the patient, that whole discharge planning and discharge process. Thank you.
Thanks, Gordon. So, Gordon, you can take a break for a few minutes now. I'm just going to bring in my colleague, Andrew Rochford. So Andrew's one of our clinical directors. He's actually on call this week covering inpatient ward, so really well placed to talk about earlier daily discharge. But Andrew, you've been really involved. I mean, you're obviously a practicing consultant gastroenterologist, ECIST clinical director, also a member of the RCP, but we've done some work with the RCP around the modern ward rounds and the RCN. I was just wondering if it's worth pointing people towards some really valuable and practical resources around ward rounds, which also features, Dr. Gordon Caldwell's work as well.
Yes, thanks, Pete, and thanks, Gordon. It's always a pleasure to hear your experience and share your learning. And Gordon was a massive early adopter of a lot of the techniques that I think we should be doing now. I was very fortunate to be part of a working group with the Royal College of Physicians when we reviewed modern ward rounds, and I've put some of the links in the chat and also put some of the challenges, and I think for me that one of the key challenges at the moment is continuity of care, and there is some mitigation around that, so we're still talking very much in professional silos, whereas if we think more about competency-based working and cross-covering, there are some generic skills that you don't need to be a physiotherapist to do a mobility assessment, for example. That's everyone's business, and I think sort of culturally we have, it might be a bit controversial, but culturally I think we have slipped a little bit into professional silos, and so it's I'm a gastroenterologist with an interest in nutrition and intestinal failure, and it seems to be a nurse's role to feed a patient or weigh a patient, where anyone can do that, right? So I think, for all of us to reflect on that. And when we looked at the RCP guidance and modern ward rounds, what we found was, and what Gordon has been talking about, is effective ward and board rounds, and they kind of can be distilled into 5 domains. One, and Gordon's a great case in point, which is they need to be well led. They need to be structured. They need to have patient involvement. They need to have effective team working, which includes patients and carers, and they need to be good education and improvement environments, because we know that that's really highly valued by our staff and has a knock-on improvement effect for our patients and other aspects of hospital care. So when we ran a collaborative with the RCN and RCP, as many on the call will be aware, and I think one of our biggest reflections was actually how urgent it is for us to go back to basics and to review the fundamental business of what we do in hospitals, certainly in medicine, which is a ward and a board round. And we were surprised by just how simple the interventions needed to be to get people walking through a board and ward round as opposed to running, because it's what we think is business as usual is definitely not happening as business as usual in my hospital and your hospital this morning, this afternoon, tomorrow, the next day. So we've got some great resources out there, including webinars. We've got written stuff. There's some templates, best case studies, including Gordon's checklist and other things. I'd really encourage people to look into it.
Yeah, thanks, Andy. So you can find all this information, including the self-assessment for modern ward rounds, on our NHS Futures site. I'm just going to bring in my colleague Ben Owens, who's an ECIST clinician, but also an ED consultant from Sherwood Forest and clinical lead there. And Ben, I mean, we're talking about the back end of the hospital, but if I was to say to you, if we could get, a third of discharges out from the inpatient wards, and for all those medical wards to be able to pull their patients at 10 o'clock, before 10 o'clock in the morning, what would the effect be in terms of patient experience, flow and safety be for you as an emergency department consultant?
It'd be huge. I think the key thing, if you look at when people arrive in the ED, people arrive, they start to pitch up about in the day. There's a small trickle overnight. They start to arrive at 8 o'clock, and by 11 o'clock they're really starting to pile in, and peak arrivals normally 11 o'clock, and that sustains through till about 5 or 6 in the evening. There's a gradual tail off of arrivals. So actually those people often need beds ideally within 2 to 3 hours of that happening. So that means really the need for beds, and obviously there's a delay from if Gordon was to discharge a patient from his ward, there's a patient would often come up from the admissions unit to that ward, so there's probably a 1 to 2 hour lag in that. So really your discharge from the ward profile needs to match the arrivals on ED profile, because you've got to have that bed movement, bed cleaning gap, and the person to move from the admissions unit through. So actually, in the ideal world, that your ward discharge profile would match your ED arrival profile, which allows for the buffer of the admissions unit and bed cleaning and bed moves and porters. And the risk here is we know that crowded EDs are at best a poor experience for patients, for crowded ED, but actually at worst it's detrimental and harmful to patients, and probably for the organisation infection control wise is bad. So absolutely big difference. And the way I always look at this is if you have long delays discharging people, and the scenario Gordon mentioned of patient going home at 6 o'clock and the bed being filled at 9 o'clock, that's not great for the patient coming into bed at 9 o'clock who's from the admissions unit, but actually that means the admissions unit bed becomes available at 9:30, 10, so the ED patient goes in at 11. Well, actually that's your ED patient back to an ED a long time, but actually it's not just those patients, it's the person who's stuck in the ambulance outside the EDs, we're sadly seeing a lot at the moment. And even more than that, it's the person who's waiting in the community for that ambulance. So that delay on a ward can not just impact the patient coming into the ward, it impacts the patient trying to get into the AMU bed, it impacts the person in the ED and the other people in the ED, but even more importantly is the people in the ambulance and the person at the end of the queue, which is the one in the community waiting for the ambulance, getting no care. So it's beneficial for several patients, as well as ED staff. So I think it's hugely important. And the way I always look at it when I'm talking to staff is to say, how would you plan your day if you knew your relative was lying at home with a broken hip at home, knowing that until you work through your day's work, etc., your relative won't be picked up by the ambulance when the system's freed up. So actually, if you think about that, whether you're an ED on a ward or an admissions unit, wherever else is, imagine my relatives at the end of that queue waiting for an ambulance. How would I plan my day to make sure that person, someone else's relative, is picked up? And if we all think about it like that, it's not just the patient in front of us we can benefit, it's several patients in the system. And I think I'd struggle to find anyone who said it's worse for that patient to go home early. It's clearly better for that patient, but also several others too. So it makes a huge difference, particularly as we are at the moment with the crowding in the system and the risk that the whole system is carrying.
Yeah, so the results of improving this are huge for patients and staff. I think we may have lost Gordon and his Scottish Wi-Fi connection. So let's open it up for some questions now, for some general questions. So if you've got some questions, if you want to put your hand up. One of the things, just while people are thinking about questions, I think I might go to my old colleague Anne-Marie Riley, which you'll probably punish me for afterwards. So and then we'll go to Peter for a question. So Anne-Marie, we worked together many years ago. We won't say how many years ago as staff nurses. Anne-Marie was a much more competent staff nurse than me. We became F grades at the same time. That shows how old we are. And you're now the Director of Nursing for UH&M in Stoke. So in terms of what we were talking about earlier on, the role of the nurse, and really came through Gordon, the trust with the nursing teams there. How do you see that in terms of in relation to earlier discharge and ward rounds and board rounds?
Yeah, I think Gordon was spot on. I think that communication between the MDT is really crucial so that you don't get missed messages. You know, and we've done lots of work with red to green, as you know, over the years, and I've done the same again here. And you know, people waiting for things that they're not really waiting for because they've not been referred, or you know, there's an assumption that something's happening that isn't happening. So I think that communication part is absolutely crucial. I think COVID's made worse the position that we already had, where you know, there's been less nursing availability at things like board rounds, and I think COVID has just made that worse. And we've got to get back to a position where we're able to, you know, it might never be the way it was, you know, as Gordon was saying years and years ago. We do need to get a system where that communication isn't lost. You know, if the nurse can't be there, we've got to find systems, whether that's digital or otherwise, that means that the patient isn't the one who suffers at the end. I just think we just need to probably think a little bit differently. You know, the days of the way we used to work probably are gone and have gone for a while. But the task for us all now is to think about how do we put the patient in the centre and make sure all that relevant information is not lost anywhere, and we're not wasting no time, and they get where they need to be as fast as they can. And that's not just for their benefit, but we know that, you know, an overcrowded ED, it's not just about the capacity or the impact of the teams, but they're not getting great care down there because, you know, they've got a ward and a half of extra patient to look after, whether that's in a department or the back of an ambulance. So, you know, it benefits the whole system.
Yeah.
Sorry, that was a bit of a waffle.
No, it wasn't, Anne-Marie. Brilliant. Thanks for that. I think we've got Gordon back. So welcome back, Gordon. We've got Peter's got his hand up. Do you want to ask a question, Peter?
Yeah, it's actually a bit of a comment more than a question, although it'd be interested in other people's perception. So what we have spoken about is the importance, especially around the complex discharges, which is what I picked up from Gordon, around the pre-planning and especially getting those out early. I think one of the things we have to remember there also is that we're often dealing with a provider at a receiving end. Trying to scrabble out a discharge at the very last minute can actually be a block there. The package of care might not be ready to be reinstated. The homes often have cut-off times if you're too late. That then has a knock-on effect if you book transport, which then can't take or is then returning them. So for me, lining those up for early in the morning and then the pre-planning, even if it means a delay from the day before, seems very beneficial. I just wondered other people's thoughts on that.
We've got Gordon back, Peter, so let's ask Gordon. Gordon, are you there?
Yeah, can you hear me all right?
Yeah, we can hear you, yeah.
Right. I think it was that recognition that things often unraveled and went wrong when you thought somebody was going home at 3 and then the transport didn't come till 5 and then it was 7 and it was dark and it was cold, and wouldn't it altogether have been better to keep them until the next morning? Of course, didn't tell hospital management that's what I was doing, because they'd have thrown their arms up in horror at the thought that I was keeping somebody 16 hours longer than I needed to. But then we showed with, as you've seen in those statistics, that although we did that, overall the effect on the whole ward was beneficial, and that the flow of patients through the ward was better, along with the quality stuff like patients getting less disturbed at night, better sleep and such like. So I think that for the complex patient, we really should be saying the discharge is in the morning, and if after that, then you don't discharge patients in the afternoon, really, the complex patients.
Yeah, thanks, Gordon. So we've got a few hands up. We've got Andrew, Paul, then Kate. So Andrew.
Yeah, thanks. It's just a quick comment, really, because Peter's point is well made. But the context is also important, which is 80% of patients leave hospital without any package of care or anything else. What we must remember is that preparing those patients and their involvement, getting them ready to leave in a timely way, is actually the easiest thing to do, because it's entirely in our gift. And I certainly know I'm on the wards this week and had to reinduct some of the team around the importance of things like writing TTAs early, because actually other people have to act on what the content is. So they tend to, certainly the junior doctors tend to leave that till the end of the day, because it's an admin task. When it's a bit quieter, they can sit and type it out, failing to understand that actually the pharmacy, nursing, etc., and the patient are waiting on that bit of paper. So I totally get your point, Peter, but I really would encourage everyone to reflect on the pathway 0, the simple discharges, and getting them earlier in the day, because they're all in your control.
But Andrew, that then goes back as well to whoever's influencing the development of information technology within the hospital, to develop an information technology system where the information from GP flows to A&E, A&E flows to the ward flows into the discharge summary. So actually doing the discharge summary isn't an onerous task, because the information's already there. In our hospital, we're held up for at least 3 hours by bad information technology on every common discharge.
I agree, Gordon. Ironically, we've got great computer systems, but we've got hardware failure, so we can't find a computer that works. So anyway, that's a totally different
we've got
question.
computers that work, but the software doesn't integrate.
We should merge.
Yeah.
Brilliant. Thanks, Andrew. Thanks, Gordon. Let's go to Paul.
Hi, everybody. I'm Paul Ryan. My question is around coordination for Gordon, particularly the multi-part coordination. So we've mentioned meds, we've mentioned transport, we've mentioned other providers, third parties. Is there any recognised or stable way of actually coordinating all these without making it a really onerous task for colleagues on board?
Paul, you presumably asked that question because you know the answer and I know the answer, which is that I've seen the system that Paul and his colleagues have developed, and to me it's frankly incredible, first of all, that the information that is available, how easy it would be to coordinate discharges, to manage the beds, the flow, the transport with that system. So it's incredible, first of all, the system exists. And the second incredible thing is that it seems to be having great difficulty getting traction in the NHS because it solves so many problems.
Yeah, I'd still like to know if there is a general approach. I mean, I'm not trying to push product on anybody, but it seems from everybody we're speaking to that there are an enormous amount of concerns about the manual overheads being incurred. So has any of the audience got some really intelligent ways of doing this beyond sort of technology? Or is it just one of those bugbears that everybody begrudgingly lives with?
what we'll do there, we'll just pause while people are thinking about that, and let's move to Kate.
Yeah, it was just a comment on what you were saying about management throwing their arms in the air if they found out you were keeping someone to the next day. And I think it's something we've all experienced. And that is probably why this approach needs to be a whole system approach from the top down. So your patient flow and bed managers aren't hounding you. And I think that comes back to the oversimplification of discharge sometimes. The ward staff need to be trusted to know that there is a reason that they're keeping that patient to the next day. And that is because it's patient-centred care and patient-centred discharge. They wouldn't want their relative being discharged late at night. And for the same reason, we shouldn't be discharging patients late at night just for the sake of a quick win. And I suppose it's a very fine balance between making sure we've got a safe ED and patient satisfaction. But I think it definitely does need to be a whole system approach to that, to have everybody on board to prevent being hounded by the bed managers and being everyone's worst enemy.
I suppose it comes back to Pete's point about measurement, that if you're making some measurements, then what management need to be able to do is allow you to experiment and allow you to have a go and allow the experiment to run for an acceptable period of time as well. And you know, Pete and all his experts there at ECIST can tell us how many measurements we need to make and how long you need to make them for to prove that you've made a difference. I mean, too often we don't make the measurements, and too often a project is pulled early on when it hasn't had a chance to prove that what it was hoping. You know, the stuff we took several weeks to settle down, that the nurses would discharge the patient without a doctor's review. And if they'd stopped the project after 2 weeks, we'd never have got that. So I think this reflects that you need to be making measurements, and management need to trust the teams to have an adequate length of time to try something out.
Yeah, brilliant. Thanks, Gordon, and thanks, Kate. 100% agree with what you said there, Kate. I think we've got time for 2 more questions, and then we'll start to wrap things up. And just to give my colleague Crystal a heads up, in a few minutes' time, if we could put the feedback form in the chat box, Crystal, that'd be good. So let's go to Ben first, and another person I know, Di Altringham.
It was just a quick comment. I've actually popped it in the chat about that question about how you get things more aligned. And I suppose it's not a solution, but it goes to show what can happen every single Christmas. Every single Christmas, we have every hospital in a few days leading to Christmas has a large number of discharges. And the only explanation I can ever give them that every single year is that the patient wants to be home, the relatives want them home, the staff want to get them home because they want to be home by Christmas, the agencies want to get it sorted out before the long weekend and getting that sorted out. And every single year we have a far higher than average number of discharges in the run up to a Christmas weekend, and probably find the organisations, the actual trust is focused on this because they're trying to create beds for that long weekend that's coming up. But it goes to show if you align staff, patients, agencies and relatives with a clear goal in mind, you can make discharges happen. So actually it goes to show what Gordon's describing. What Gordon's describing is that everyone's got a clear date, we're all working to the same goal with a reason for it. And Christmas shows us every year that it can be done. Prior to that, the other quick point was the question was to make. I think Gordon's made really well was it's just not as much about discharging the patient early. It's actually about filling the bed early too. So there's 2 parts. One is discharging somebody, but 2, actually, it's about making sure your bed is filled. And actually, some places will discharge people by midday, and then the bed's not filled till 4 o'clock, and that doesn't improve the ward, doesn't improve the ED or the ambulances. So it's not just the discharge that's important; it's actually filling the bed that's also important, and that can sometimes be lost in this. But I think he makes the point really well.
Yeah, brilliant. Thanks, Ben. They're great points. So last question, Di, lovely to see you. Over to you.
Lovely to see you too, Pete. So I'm just, having listened to the presentation, I'd just like to say to Gordon, I didn't feel that he was slowing the process down. I felt, if anything, it was just really good interdisciplinary decision making. And actually, if those patients hadn't been under his care with that approach, would they have stayed a lot longer in hospital? So we know we've got patients who are delayed by days, not by hours. And I think it's always a good plan to instigate an early discharge. I think the other thing, and it's just something food for thought for us at SWBH, we're working on a fundamentals of care approach. And I think listening to the view across the room is around how we integrate our ward rounds with that, because I don't think that's something we've thought of. And I think it was Andrew who said about it being a fundamental, and I think that it should be a focus point for ensuring that we've got that good interdisciplinary decision making, looking at the fundamentals of care, but also involving the patient in that decision making. So just thank you for inviting me today.
Yeah, thanks, Di. As ever, it sounds like you're doing some great work. The modern ward round stuff is really good, and the templates Andrew and the members of our team have developed are really simple to use. It's all about multidisciplinary teamwork. So I think we're coming to the end of the session now, if there's no more questions. So thanks ever so much for everybody to attending. If you could do us the favour, we love having feedback, whether it's good, indifferent, bad. We're not sensitive at all. It probably will take you about 2 or 3 minutes to do, and it helps us sort of improve as we go along. So our next webinar is next week at the same time, next Thursday, 12:30 to 1:30, and we've got one of our clinical associates, Dr. Liz Lees-Deutsch, who's a nurse consultant, but she's also an academic who is our go-to person for criteria-led discharge, which is a subject next week. So if that's something you're interested in, which sort of leads on from earlier discharge, please join us. In terms of some of the great work that we've heard today, we're always looking for great work to share with others. So if you've got good examples, I'm thinking Di, I'm thinking Anne-Marie, but lots of you, please contact us and let's share your good work. But for now, thank you very much for attending. A special thanks to Dr. Gordon Caldwell, who's one of my heroes. Thank you, Gordon, and thanks everybody. So we will see you all soon.
Thank you.